This video will help you understand the changes that might happen in your body if you are trans or gender diverse and take testosterone for gender-affirming care.
Changes are to some degree based on the dose and length of treatment. It's hard to pick and choose individual changes, but at QueerDoc we love supporting nuanced care and individualized treatment based on your goals.
We believe gender is infinite.
We believe gender is infinite.
And want to help you find the treatment that fits best for you, whether it involves testosterone or not.
Testosterone is a hormone made by our bodies. Bodies with testicles usually make more of it than bodies without testicles, but almost all bodies make it. It can also be made in a lab. The testosterone we prescribe at QueerDoc is made in a lab, but has the same chemical structure as the testosterone made by bodies. We often call this type of testosterone bioidentical. Testosterone does many things in the body, and if you start taking it, your body will change.
These changes may be something you want, which we would call a benefit, or something you don't want, which we would call a side effect or a risk.
Your set of benefits, side effects, and risks is unique to you and depends on what you want for your body. We will try to give a general timeline in this video for when these changes will occur, but we can't predict it exactly. The timing of when changes start varies by individual and dose taken. Most changes happen gradually, so if you notice something you don't like or don't want, you have time to talk to your clinician and decide if you want to slow down or stop taking testosterone. These changes can be permanent, semi-permanent, or transitory, meaning they go away if you stop testosterone.
We'll mention when changes are permanent or semi-permanent. If we don't mention it, then changes will revert or go back to how your body was before testosterone if you ever stop taking it. Testosterone can cause these changes in your body. Thinning or loss of head hair. Hair loss is often genetic, which means that the tendency to lose hair is passed down through families. The genes which affect testosterone-related hair loss are present in eggs, but not in sperm. If baldness is common among the relatives on your birthing parents' side, you're more likely to lose hair when taking testosterone. There are some interventions that can slow down or limit hair loss, so let your clinician know if you want to talk about these. Head hair loss is gradual, but usually noticed within the first year of taking testosterone. Hair loss can be a semi-permanent or permanent change. Once a hair falls out, the hair follicle has about a year before it loses the ability to grow new hair. If you stop testosterone before that hair follicle stops being able to support new hair, you might be able to regrow lost hair. After that time, about 12 months after the hair falls out, your hair loss would remain even if you stop testosterone and would be a permanent change. Growth of facial hair. This is also a biological family or genetic trait. If no one in your family grows a full beard, it is unlikely that you will. Facial and body hair usually start to change in response to testosterone in the first 6 months, but can take up to 10 years to fully develop. If you want facial hair without the other effects of testosterone, you could consider applying a topical medication like lantanoprost to the places you want hair. You can also use makeup or prosthetic hair. Facial hair that grows while you take testosterone remains if you stop testosterone. Because facial hair stays, some people choose to take testosterone until they have the full amount of hair they desire and then stop testosterone. If you don't want facial hair, but do want the other effects of testosterone, there are procedures like laser and electrolysis, which can remove existing hairs and prevent new hairs from growing. Because hair can be managed this way, we consider facial hair growth to be a semi-permanent change. Testosterone thickens your vocal cords, and this makes the pitch of your voice deeper. There is some very limited evidence that suggests starting with a lower dose of testosterone and titrating your dose up slowly may help achieve more change and a lower voice overall. Voice changes actually seem to start with your very first dose of testosterone, but most folks won't notice them for about 3 to 6 months. People who are vocally trained might start to notice vocal instability and changes in their range very quickly. The voice will reach its final destination after about 2 years of testosterone therapy. Testosterone does not affect resonance, tilt, word choice, or nonverbal communication. These are all ways society interprets gender when hearing a voice. Even with the changes in pitch, you may want to work on some of the other parts of vocal expression through vocal transition. Some folks choose to take testosterone until their voice sounds the way they want and then stop. You can also try vocal transition with online courses, coaches, or speech-language pathologists, or pursue vocal fold surgery to lower your voice. Voice deepness persists even if you stop testosterone in the future. If this is unwanted, you could use vocal coaches or surgery to access a higher pitch, making this a semi-permanent to permanent change.
Oilier, thicker skin, and maybe some acne. Skin responds to testosterone by getting thicker, oilier, and less soft to the touch. Testosterone stimulates increased sebum secretions from sebaceous glands. More oil from oil glands, plus clogged pores from skin changes, often lead to some acne, especially in the first 2 years of testosterone therapy. There are treatments available for acne, so please let your provider know if you are worried about acne. Also, thicker and hairier skin sometimes means it is less sensitive to touch. Change in body odor. Your body odor will change in smell, and your personal smell may become stronger or more noticeable. Sweat and your body temperature. Testosterone can increase your basal body temperature. You might find that you feel cold less often or hot more easily. You may notice that you sweat more often or more profusely. More body hair. Testosterone will increase the darkness, thickness, and fullness of body hair. These changes in your body hair will persist even if you were to stop taking testosterone, but you will not continue to get new body hair if you stop testosterone. Like facial hair, this is considered a semi-permanent or permanent change, as you would have to pursue hair removal procedures to reduce body hair. Fat redistribution. The layer of fat under your skin will probably get thinner. This gives you a more angular and veiny appearance to your face, body, arms, and legs. You will also tend to store less fat around your hips and butt, and more in your midsection, giving you a little more linear silhouette. This usually takes years to fully develop. The combination of skin, hair, and fat changes may also change how you experience physical touch and pressure. You may be less sensitive to skin contact. Bigger, stronger muscles. Testosterone will increase the size and strength of your muscles to a degree even without exercise. These effects can be amplified by exercise or worked towards with exercise alone. Building muscle too fast can increase your risk of tearing a tendon, and this can be very hard to heal. It's important to build muscle slowly over time to give your tendons time to strengthen as well as your muscles.
Less chest or breast fullness. Previously developed breast tissue will not go away when you take testosterone, but it will become less full and less fluffy or pillowy, which may make it easier to bind.
Weight change. You may gain some weight, usually about 3 to 4% of your body weight. This is probably related to your muscles getting bigger.
Also, testosterone does make some people more hungry.
Bottom growth. Your clitoris or phallus gets larger, and this change persists if you discontinue testosterone. You may experience some uncomfortable sensitivity or growing pains.
These changes may start in the first few months and take a year to develop. The sensitivity or growing pains stop once the full growth potential is achieved. However, morning wood engorgement and more intense sensation is not uncommon for the duration of testosterone therapy. You may experience changes in the way you experience sexual stimulation or pleasure.
You will still be able to orgasm, but may need to use different techniques to get off, and it may feel different when you do.
Front hole or vaginal dryness and atrophy. Testosterone changes the tissue of your genitals. You may notice discomfort with receptive sex or masturbation. This discomfort or irritation may happen even without receptive practices. Sometimes it can feel like painful urinary symptoms. dryness, roughness, or burning. You may even be more susceptible to a urinary tract infection.
In fact, we actually think starting estrogen treatment for front health wellness should be done within the first 6 months of testosterone therapy for most folks. Talk with your clinician if you experience this, as there are interventions and treatments that can help.
Sex stuff. Testosterone often makes people think about sex more often or more intensely. It may make you want to have sex or orgasms more often. It may change what you find sexually interesting or appealing, or what gets you off. It often makes people more visually stimulated than previously.
Cervical changes. The cells of your cervix change. This makes it more challenging to collect an adequate sample for cervical cancer screening, sometimes called a PAP or Pap smear. We often recommend frontal or vaginal estrogen prior to attempting cervical cancer screening to improve the likelihood of a successful sample collection.
Decreased fertility. Fertility changes depending on how long you're on testosterone and your age. While you are less fertile when you are on testosterone, you are not completely infertile, even if your periods have stopped. In fact, some people have gotten pregnant while on testosterone therapy. Talk to us about birth control if you are likely to get sperm anywhere near your genitals, and if you think you may want to get pregnant in the future. We have pretty good data showing that people who are reproductively mature, which means 2 years past the start of their periods, when they start testosterone therapy, are able to access fertility even after 5 to 10 years of testosterone therapy. Fertility access after more than 10 years of testosterone therapy has less data behind it and is probably less likely.
Reproductive tract cancer. You don't have an increased risk of cancer, and you do not need a hysterectomy if you do not want one.
Stopping periods. If you currently get a period, testosterone may stop your periods depending on your dosing. Contraception or birth control and some other medications can be used to stop periods in addition to testosterone, or you can take them on their own. This usually takes about 6 to 12 months depending on the dosing.
Emotional stuff. Mood and emotional changes are often the first changes noticed and can be seen with the first few weeks of starting testosterone. People often report feeling an improved mood, feeling happier, calmer, better. People often describe their emotional experience on testosterone as more simple and less complex.
They say their emotions may be less intense but more stable. Some report they feel more secondary emotions than they did previously. Secondary emotions are internal reactions to the primary or first emotional reaction felt, such as feeling anger after an event that first provoked fear. Some people may find that they are less tearful. People also find they may be a little more irritable, but not angrier.
If you feel intense increases in anger or rage, potentially your testosterone dose was started too high or escalated too rapidly. Physical and safety or discrimination. Being queer and trans, especially when you are more visibly so, increases your risk of minority stress, discrimination, and physician violence. These risks are amplified by any intersexual identities.
Data is limited, but there are some known possible risks with testosterone therapy.
Cardiovascular disease is commonly known as heart disease. Heart disease is a group of conditions that lower the heart's ability to pump blood, or the body's ability to get enough oxygen-rich blood to all of its parts. Cardiovascular disease does occur at higher rates among trans people, but we believe that to be related to minority stress. Minority stress is the additional impact to daily life caused by prejudice and bigotry. We don't have a lot of research about changes in heart disease risk for transgender people taking testosterone, but we don't think that taking testosterone significantly increases your overall risk of cardiovascular disease. And we do have information to indicate that transgender people taking T and who have heart disease are not sicker overall compared to cisgender people. This is all made more complicated because testosterone may cause changes in other body processes that are commonly used to estimate heart disease risk. And heart disease risks often build on each other. You can learn more about cardiovascular disease risk in one of our other videos.
Testosterone can cause increased red blood cell production. Smoking cigarettes, sleep apnea, living in high altitudes, and other conditions can also cause your bone marrow to produce more red blood cells. Having more red blood cells may make your blood thicker and may impact how smoothly your blood flows and how it clots. We recommend lab monitoring to keep an eye on this.
Systolic blood pressure rises on T. Systolic blood pressure is the first number in a blood pressure reading.
This is a measure of the pressure inside your arteries when the heart beats. So it is a description of how hard blood pushes against your artery walls. Higher systolic blood pressure can indicate that blood vessels are getting damaged, but we don't know for sure if taking testosterone causes this damage. Just that systolic blood pressure does rise on T.
It could be that systolic blood pressure rises because the blood gets thicker on T, and the heart has to push harder.
And by thicker, we mean that testosterone produces more red blood cells, making the blood thicker.
If you have problems with your kidneys or your blood pressure already, make sure you talk with your clinician about blood pressure effects and recommended monitoring.
Taking testosterone might raise your risk of liver disease if you have other risk factors for liver disease. If you already have liver disease, it may get worse. The overall rate of liver injury after 12 months of testosterone therapy in a 10-year study of over 1,000 testosterone people taking testosterone was 0.4%, which is very low.
Liver disease risk factors include exposure to toxins, including alcohol, some diseases such as hepatitis and other infections, and physical damage to the liver.
Change in cholesterol. There are several different types of cholesterol, which are fats that are necessary for your body to do things like create new tissue for healing and growth. To be in your best health possible, you want higher levels of high-density cholesterol and lower levels of low-density cholesterol. Testosterone does not appear to change levels of low-density cholesterol, but may slightly lower the levels of high-density cholesterol. Triglycerides are another fat used by the body, and like low-density cholesterol, better heart health is associated with lower levels of triglycerides. Testosterone may increase triglyceride levels slightly. Lower levels of high-density cholesterol and higher levels of triglycerides in your blood, combined with damaged blood vessels, may mean that the insides of your blood vessels are more likely to have fatty buildup.
Heart attacks. Transgender people taking testosterone have a higher risk of myocardial infarction, which is a heart attack, compared to cisgender women. But there is no difference compared to cisgender men and no difference in outcomes. A heart attack is when blood flow to the heart muscle is limited or stopped. This causes damage to the muscle and makes it much harder for the heart to do its job of pumping blood. Heart attacks are often caused by blocked blood vessels.
Strokes. A stroke is when the blood supply to the brain is limited or stopped, or a blood vessel inside the brain bursts. There's no difference in how often strokes happen between transgender people taking testosterone and cisgender men or women. Testosterone might impact factors that could increase the likelihood of blocked blood vessels, and thus the risk of a vessel bursting or blood flow to the brain stopping, but there is no clear link.
Diabetes. Diabetes is the body needing more insulin to be able to manage sugars, also called glucose, in the blood. Taking testosterone does not seem to have any impact on how the body uses glucose or the levels of insulin present in the body. However, testosterone therapy may lower levels of a chemical that regulates insulin use, and lower levels of this chemical is associated with the body not using insulin as effectively, which could lead to diabetes. If you already have diabetes, starting and changing your dose of testosterone may affect your insulin needs. Work with your diabetes management team to watch your blood sugars more closely at those times.
Blood clots in other parts of the body. Thromboembolism is when a blood clot forms somewhere in the body, then travels to another part, often the legs or lungs, and gets stuck in a new location. Increases in these types of blood clots have not been seen in gender diverse people who did not have the other conditions that would raise the risk of blood clots and who are taking testosterone. A 2021 meta-analysis confirmed that there is no link between testosterone therapy and thromboembolism risk.
If doing microdosing or low dosing, the lining of the uterus, the endometrium, may get thicker. This is called endometrial hyperplasia. Hyperplasia can lead to abnormal cells and a higher risk of endometrial cancer. While testosterone can stop periods, it may not stop the body from growing the lining of the uterus. This is more likely on very low doses of testosterone because endometrium growth depends on estrogen, and bodies on lower doses of T are more likely to continue making estrogen.
If you choose to take low doses of testosterone, we recommend you discuss endometrial lining stabilization with your clinician.
We do encourage regular blood pressure monitoring every 3 months in your first 1 to 2 years of therapy, and regular blood work to keep an eye on some of the risks. Baseline blood work or lab tests may be recommended. Our recommendations will be based on your pre-existing health and your personal values. Some people may choose to decline baseline lab tests, but will need to talk to their doctor about what risks are involved in not doing baseline lab work.
Testosterone can be taken in many different ways. They come in pills, nasal gels, gels for your skin, injections, and pellets.
Patches are no longer available in the United States. Oral testosterone was FDA approved in 2019. There is currently no generic available, making it more expensive. The pills cannot be cut or crushed, so the dose is less able to be individualized. Gel and injections are the most commonly used forms of testosterone. They tend to be both more affordable and the dosages are easier to individualize and change.
The gel is usually applied every day, usually to your upper arms. It can cause more hair to grow at the location where it is applied. After applying, you need to wash your hands and cover the area with clothes. It is recommended you shower prior to any skin-to-skin or skin-to-animal contact due to the risk of testosterone exposure to other people or animals. It is also suggested to wash your laundry in separate loads. Injections are most often done once a week. We usually recommend a subcutaneous injection, which uses a smaller needle rather than intramuscular injections. You can learn more about injections on our self-injection page. Thanks for learning about testosterone with us.
There are other medications that we sometimes use in gender-affirming care to reduce bottom growth or body hair, to reduce head hair loss, to increase facial hair, or to stop periods, besides to or in addition to testosterone. We encourage you to talk to your clinician about these options. We look forward to helping you with all of your gender care needs.
We look forward to helping you with all of your gender care needs.